When it comes to drug use and abuse, the concept of harm reduction is not new, but it is still controversial and politically polarizing. Vancouver Coastal Health is looking at new ways to provide harm reduction services. Dr. Patricia Daly is Vice President of Public Health and the Chief Medical Health Officer with Vancouver Coastal Health. She's also a clinical professor. It is my pleasure to welcome Dr. Patricia Daly back to Studio 4 to tell us more. And one busy woman you are.
Well, yes.
Let's go right to harm reduction. We hear so much about it, certainly the 4 pillars approach, all of that. How do you define it?
It's very simple. We're trying to reduce the harms associated with drug use while we try and treat people and get them off their drugs. If you have a relative, a son, daughter, sibling who's a drug user, you want to ensure that they don't die of an overdose, they don't get HIV, hepatitis C, or some other serious infection while they're using their drugs. Of course, our goal is always to prevent people from using drugs, treat those who are addicted to drugs, but we don't have a magic pill that can treat people and get them off their drugs immediately. Addiction is a very complicated medical issue, and all harm reduction does is keep those people alive and safe while we try and address their addiction.
And as you suggest, it's a medical issue. Some would say it's only a criminal issue, but most thinking people I know say it's a health issue. It's a medical issue.
That's right. Addiction is a medical issue, and people can be addicted to legal drugs. In fact, it's our legal drugs that cause the greatest harm: tobacco, alcohol, prescription drugs, or illegal drugs. So whether the drug is illegal or not, the issue is a medical one, and it's addiction.
I think they've done many studies on, do you not take a drug because it's illegal, or do you not take a drug because you simply don't want to take the drug? And I'm not sure, knowing the pot smokers, I know that they refrain because of, pot is illegal.
That's right. We know that marijuana smoking is widespread, and actually the current system has not decreased marijuana use in the population. So that's another drug that we need to look at.
And on site as a coastal health officer, as a public health officer with medical marijuana.
Medical marijuana it's now here in Canada, and there are some issues with the current program with Health Canada, but I think as medical health officers in this province, what we really would like to look at is all psychoactive substances, those substances that people take, such as alcohol, even tobacco as a psychoactive substance, illegal or legal drugs, and how we're currently approaching those. We think there needs to be a regulatory model, that the current model where some happen to be illegal, some are legal and actually promoted is not appropriate. Both those extremes lead to harm, and what we really need to think about is a regulatory approach to those psychoactive substances.
So prevention, first pillar of the 4 pillars, treatment second.
That's right. A lot of people object to harm reduction. I've heard politicians say, well, we believe in prevention and treatment, not harm reduction. They're not mutually exclusive. The beauty of the 4 pillars approach is that we look at all of the 4 pillars at the same time: prevention, treatment, harm reduction, and enforcement. And in fact, in this country, we spend far more on enforcement than we do on the other 3 pillars. In Vancouver Coastal, we have greatly expanded our treatment approach to drugs in the last decade. We spend about $45 million on mental health and addictions treatment, $3 million on insights. So some people criticize us for our harm reduction approach. In fact, it's not just a harm reduction approach. We are also expanding treatment, and we're also looking at expanding prevention.
And as you know so well, the federal government spent hundreds of thousands of dollars fighting Insight, lost the case in the Supreme Court, is my understanding. Is that done now?
We think it's done.
Do we know?
Yes, we have our exemption to operate Insight, and as long as conditions remain the same in Vancouver, and we can demonstrate a need for a supervised injection facility, I don't see any further challenges to that facility. In fact, we are likely to see more facilities. The Dr. Peters Centre here in Vancouver has written to Health Canada and advised them that they will be applying for an exemption to operate supervised injection at that facility.
Okay, and what happens at the site?
At the site,
on the ground.
At Insight, people come into Insight, they're registered, so we keep track of all the users. They have to bring in their own drugs. We don't supply the drugs. We supply all the clean equipment necessary for them to safely inject drugs. There are nurses on site who can ensure that if there is an overdose, it's treated promptly. And we're very proud of the fact that since Insight has been open in 2003, there have been many, many overdoses, but no deaths, because that treatment is immediately available. people who inject drugs on their own, in their own room, let's say, in a hotel in the downtown east side, are much more likely to die if they suffer an overdose. And we've also shown that we can reduce infections from people who are injecting, that they can inject in a safer manner than they used to before the facility was open.
Okay, so what about the supervised part? Nobody stands over you as you're injecting heroin with a clean needle, albeit, and says that's too much or
No.
that's too little.
No, and the nurses do not inject for you. We need to make
Right.
that clear. But it's to talk about how to do it in a safe manner so that you reduce the risk of infection or overdose. The other great thing about Insight, which I don't think we really anticipated this when it opened, is it's proven to be a very good way of engaging drug users into treatment. In fact, we have a treatment facility right upstairs from Insight called On-Site, where people can detox and start the treatment process. So in addition to injecting safely, we're getting them on the road to stop using drugs if they want to do that.
Well, as you know, that's the end goal, has to
is.
be.
It is.
Or it makes no sense.
That's right.
In Europe here or Africa, it just doesn't make sense. The end goal would be to help people get off drugs.
That's right.
And not die.
That's right.
Highly controversial, as you know.
Although widely supported in Vancouver, I think, by the
I
population
think
here.
it seems to be, and yet there are people that shake their head and say, what? You give somebody a free crack pipe or a free needle or a clean needle so that they can get high, or you give somebody booze so they don't drink shaving lotion to help an addict or hinder an addict. That's where the issue is.
And it can be
for
hard.
many.
It can be hard to understand. If I had a vaccine that could prevent people from becoming addicted to any drug, I would spend all my money on that and vaccinate people. But we don't have that. Prevention is difficult. Treatment is very, very difficult. We don't have a magic treatment. It can take many, many attempts for people to get off their drugs, just like it can take many attempts to stop smoking. And while we're doing that, we don't want that person to die of a drug overdose. We don't want them to get HIV, which is going to cost the healthcare system hundreds of thousands of dollars. We don't want them to get hepatitis C. All harm reduction does is prevent those harms while we do our very best to get them off their drugs.
And it doesn't encourage them to use more. The point is with an addict, my sense, not being the doctor, is that they use no matter what.
That's right. And in fact, that's something we studied at Insight. We wanted to ensure that we weren't encouraging more drug use. And the BC Centre for Excellence in HIV and AIDS did fantastic research at Insight, and they demonstrated there's no evidence that it increases drug use.
I was raised in a family of really good alcoholics.
Yeah.
And it didn't matter what you said or if you hid the booze, or they're very clever and they're addicted.
That's right. And as you know, it can be very, very difficult to address alcoholism. If you're a smoker, even if you're committed to quitting, that can be very, very difficult. Those people who happen to be addicted to illicit drugs, it's no less difficult to start that treatment process.
Well, politically, the Liberal Party has come up with a policy. I wasn't at the meeting, so I have no idea exactly what their policy is, but it's about legalizing and regulating marijuana.
And I think that's a good thing.
On side with that.
That's right. We need to look at regulation because the war on drugs has not worked. We have tremendous problems with organized crime and the marijuana trade in this province, many harms associated with that. And it's time we start looking at other approaches to reducing the harms associated with
Well,
drug
when
use.
the law doesn't work,
That's
you have
right.
to look at other approaches. The treatment part of the 4 pillars, always an issue. Somebody is ready for treatment, needs treatment, and it's not there.
That's right.
The good addicts I know, and good probably isn't the right word, but committed addicts, when they're ready, when they've had an aha day or a down and they're ready and the treatment isn't there.
It can be difficult. And one thing we've really worked on at Vancouver Coastal Health, we get a lot of publicity about Insight and our other harm reduction programs, but we have addressed our treatment to make sure that people don't have to wait. So if someone's ready to start treatment, we have a single point of access into our treatment. We have many options. There's residential treatment, there's detox where people can get through that initial period when they might suffer withdrawal. We have home treatment. Methadone, we've expanded methadone accessibility in Vancouver. So there's many, many options, and that's something we've really worked hard to improve, because you're right. When someone's ready, they don't want to be told you've got to wait 2 or 3 weeks to start your treatment.
And what is methadone? I know what it is, but how does it work?
It's prescribed by physicians, and it's a substitute for heroin for people who are addicted to heroin, taken orally, longer acting, so it can get people off their heroin without suffering the withdrawal. And we've seen some good success with methadone treatment. It's not for everybody. It's something that does work for some people, but some people fail methadone, which is why we're constantly looking for other treatment options. The most recent was the Naomi study, which looked at actually giving heroin to heroin users. And a follow-up to that has recently started in Vancouver called the Salome study, where we're giving another legal drug that works in a similar manner to heroin to see if that might be effective in treatment. So we're always looking for new treatment options.
But why wouldn't somebody who's an addict be addicted to methadone instead of heroin?
Well, you can. That's a criticism of methadone, that you can become dependent on methadone as well, but the goal would be to try and wean them off the methadone. It is an option that's taken orally, so there is some benefit in that you're not injecting a drug. But the goal is not to stay on methadone for the rest of your life. It's to try and get off the methadone as well, under the supervision of a physician.
Does any supervisor check the drugs that come into a site? For instance, if you have heroin cut with something lethal, if you have crack?
We don't do that, and that's a caution that we advise people, even those who use Insight. We don't know what drugs they're bringing in. We do try and monitor bad reactions to drugs, so we're constantly looking at number of overdoses that might occur. We've seen, for example, more heroin overdoses within the last year or two. We don't know if it's because it's more potent, and we do put out advisories to the community. The recent deaths associated with ecstasy is another example where the coroner in Calgary determined there were other substances being cut into ecstasy that may make it more harmful. So we're constantly working with our partners, the coroner, the police, to try and identify if there's any contaminants or concerns with the drugs on the street.
And is ecstasy an addictive drug?
It's not
Sounds like a silly question, I know.
It's not considered an addictive drug, nor in how it's normally taken. The concern with ecstasy is it's a different profile of drug user. We're seeing a lot of young people who might use it on occasion, who may not feel that it's a harmful drug to take. And of course, it can be lethal. So we have been putting out advisories, most recently associated with those deaths that we've seen both in Vancouver and in Calgary in recent weeks, to let people know that this is not a safe drug. Don't take it. And if you do, certainly take it with somebody who can monitor you after you've taken it. And if you experience any side effects, seek medical attention immediately, because some of the deaths might have been prevented if people had gone to hospital.
Exactly, and emphasis on the any side effects.
That's
anything.
right.
If you have a headache, if you're throwing up,
if
whatever,
you're feeling hot or
that's
overheated,
a side effect.
That's right.
And that's MDMA. And when we come back, let's talk about what it could be cut with, or what's the worst option, really.
Okay.
Dr. Patricia Daly, our guest, Chief Medical Health Officer, Vancouver Coastal Health.